I hadn't seen that kind of healing. That was the first time I'd seen it. And then I said to Brian, they've mixed up your MRIs. That's not, come on, can I explain it? Not really. Strength begins in the brain as a thought.
We're trying to do things at scale where we're trying to find the commonalities that help most of the people most of the time.
Yeah, you've got to think through the linkage. How many car mechanics are there in the world? Hundreds of thousands. How many can build an F1 race car that will win an F1 race this year? Probably a handful of people in the world.
You were trying to recognize a pattern.
A great clinician has an almost sixth sense, an extra sensory perception.
Good morning. Welcome. We have the great pleasure today of hosting Professor Stuart McGill from the University of Waterloo. The man needs no introduction. A lifetime of experience in spine biomechanics, research, rehabilitation protocols in multiple avenues from elite athletic competency in sports through to corporate, military, industrial applications, ergonomics, as well as just the average clinical case, which comes with back pain. A wealth of knowledge, a wealth of experience, and I've been very grateful to have your mentorship over the last number of years. It's, I think, believe 10 years now that I've been lucky to start learning from you and continue with mentorship. We have a bunch of amazing questions today for you. We would like to go in a few different directions. Just to sort of segue into our conversation, I would like to talk about the interdisciplinary approach that Marcin and I have been able to enjoy together in Prague as a fitness gym and as a chiropractic clinic, working together and collaborating. I was hoping that Marcin could give us his story about how we met actually and how we began delving into your work together.
I've had the pleasure of meeting Stuart McGill already in my university back in England and at the ACC, where I was introduced to his method. It was also a common theme that we spoke about in the functional, let's say, movement or functional exercise classes throughout the chiropractic program. And then you pick up a little nugget there while in school without really having the full patient base to work with. So you don't really have a chance to test things the way one would want. Then later we met in Amsterdam at a workshop hosted by Mark Beavers. That was an interesting one. We had Pavel Kolash there as well. Then in Parker Seminars in Vegas, that's a pretty big chiropractic event. So chiropractic is very familiar with Stuart McGill's work. But I must say it took me quite a bit of time and an understanding of how I can actually apply it, because we're going from adjusting people, using manual therapy, then bringing exercise into it. And when I arrived in Prague, I found myself searching. I had a look at Stuart McGill's website, the BackFitPro, and I saw that Paul was actually next door. So I went to knock on his door. And we've been working together ever since. And what I've learned is that having somebody to work with, like Paul, who is a BackFitPro provider, has really excelled the results of the patients. And we can discuss why that is and how that may be working throughout this podcast. It's been a very fruitful relationship, which brought us here to this point.
Basically for us, it's become a backbone of what we do at advanced training. We have a couple of strength coaches at a PhD level. We have a couple of physical therapists as well who are training people. So we have a lot of hands on deck. But one of the things that I find is that the BackFitPro methodology and the basic foundational exercises are kind of a backbone of everything that we do. And so if I put a person in somebody else's hands, I can be rest assured that I will use their skill sets to the best and to the highest effect while retaining, let's say, continuity or through line of the foundational training. I would like to start with some principles and philosophy of the system itself. And maybe we could talk about why individualization matters. You're known for beginning many of your answers with "it depends," and you're kind of famous for that. Can you explain why such nuance is essential and why something helpful for one person could be harmful to another? Perhaps that's a good way of starting off the conversation.
Well, good morning, Paul and Marcin. People form a spectrum of just about every characteristic you can think of. They've got different histories of injury, They've got different personalities, different comorbidities. They have very different body types. I can go on and on. Let's just consider a variable like response to dosage. You could say to one person, do 10 reps of a deficit deadlift, and that might stimulate them. And then to the next person, that exact same dosage of that exact same exercise technique and choice would create raging sciatica. So if we're working with people, we have to be guided by considering the individual specifics. And therefore, the answer is always, it depends. We have to establish context, goals, characteristics of the person, and then we can use the scientific principles within mathematical variability to arrive at the solution for them. So the answer is, if you're dealing with people, it has to start with it depends.
You've taught me of every case, of thinking of every case like an experiment. We call this experimental design and the art of clinical discovery. How do you determine what stays in a program and what gets removed based on a person's unique response?
It starts with diagnosis and understanding the mechanism for why that person isn't functioning optimally. So in every branch of medicine and health, diagnosis is essential, but we think of it slightly differently, perhaps. Typically, a physician might order a blood test, or they might take a picture and use an MRI. And then people have discussion groups about, was it a positive test, a false positive, a false negative, etc. But we approach assessment from an engineering perspective. It's a troubleshooting exercise. We will make some observations. We'll test some possibilities. That's provocative testing. We purposefully provoke the pain or discomfort at a very mild level, knowing exactly what we did to provoke it. So now we know with a bit more precision what were the variables that made it worse. What were the variables that made it better? And then we start probing the antidote. Can we really reduce the sensitivity with a certain motion, a posture, a load, a stress concentration, a temperature, a thought, whatever that happens to be? And then we explain and explore alternative explanations that might exist, because if someone comes with complex back pain, it's rarely one thing, it's a constellation of things. We have to converge on what the pathway is and what it isn't. Then we have to keep going. If we're going to apply some kind of intervention, whether it's an exercise, we then have to start talking about what's the dosage? What's the tipping point that we have to stay underneath to create positive adaptations? If we cross the tipping point, exactly the same thing in a higher dosage then makes the whole situation worse. What's the rest schedule, the deload schedule to allow the adaptations to occur? There's a little bit of a essay, I suppose, a short essay on what stays in the program and what gets removed. It's a continual process of this troubleshooting assessment. And an exercise is never just a therapeutic exercise. There's always an element of continual diagnosis and updating the status of the person.
That's a really great point that you just made, because I think a lot of people, when they judge a methodology, its efficacy, and when they begin to critique a methodology, they're looking at one part of the process without realizing that the process changes as the individual changes. And that's just something I wanted to put out there as a thought.
And over time, has this constellation of things, has it changed? And I will say one more thing. The way I see it is you're trying to recognize a pattern. And let's say I've been doing this for X amount of years and you've been doing it for a lot longer. And have you seen that the pattern changes? For example, if we will mention that there are triggers to a back pain, whether it's a thought, whether it's an inflammatory issue or a certain movement pattern. Did you see that the trend has changed, and how has it changed to where we are now?
I would have to say that yes, in some ways, because the clinical communities go through eras. When I started in the 80s, for example, it was interesting that the clinical professions like physical therapy, as a group, now, of course, there were exceptions, but as a group, they believed that the pelvic tilt was a good intervention, and that most people with back pain had a increased lordosis, a hyperlordosis. So flexion exercises, Williams exercises, which were, sit-up based, and doing a pelvic tilt was widely promoted. So we would see people with more flexion-based issues. And then the next trend after that was McKenzie, directional therapy with a lot of extension-based. Well, naturally, anyone who was exposed to a McKenzie, say something like a floppy push-up, well, that might be perfectly legitimate and the best thing to do for 2 weeks, not realizing that the clinician might say, well, do a few every day. Well, even when they're better, keep doing them. They didn't change. So what that group then started to do, they would come here with extension intolerant pain because the facets were sensitized after a year of doing floppy push-ups. And then we got into, that was the transverse abdominis era. And now we're into an era of, just get strong and that will fix a lot of back pain. And now we see many more people presenting at the clinic with, well, how did you hurt your back? Oh, well, it started with a heavy deadlift. And again, don't misinterpret me. There's nothing wrong with the deadlift as an exercise. If the person hurt their back doing deadlifts, chances are it wasn't that they were weak and more deadlifts will cure their back pain. They now have some tissue damage. It requires a very different approach. So if that answers your question in terms of what I have seen over, I guess I'm close to 50 years now of being in this, I'll say arena, not a profession. And those are some of the trends that I've seen. Who knows what's coming next?
May I just interject? Because I was listening to your answer, Professor, with my trainer hat on. And of course, what I'm hearing come from you is these are programming errors. My immediate thought is not to blame the back extension or the movement itself, but to say, well, these people are obviously overdoing it in some way. Is it so? In that example of that McKenzie floppy push-up, is it the movement itself, or is it just the sheer volume and frequency that's the problem?
It's the latter, because we know we were one of the first to do the investigations that if there is an open fissure in the disc, which is only caused really by one mechanism, and it's loaded repeated flexion to excess. The collagen delaminates posteriorly, and the nucleus gets literally hydraulically pumped through the posterior annulus. If that occurs, you can reverse that with floppy push-ups. We measured that, but there were nuances to it. It only worked if there was 70% of the original disc height remaining or more. In other words, if the disc was flattened, that floppy push-up idea wouldn't work. But then we were concerned as more and more people came in with extension intolerant, and we would measure sensitized facet joints because of the volume, as you point out, was too much. So it wasn't the exercise, it was the volume was too much. And it was, you talked earlier about knowing when to remove an exercise. Well, it should have been done for 2 weeks and then removed from the program because the therapeutic benefit had been achieved. And then stop doing the floppy push-ups. And then we found out, well, is it the motion of extending in the floppy push-up? Because the McKenzieists at the time were saying you literally pump it back. Or is it the posture? And if you simply laid on your tummy with two fists under the chin, or maybe on the elbows, I don't know, that would be nuanced to the individual, is that just as effective at returning the disc through the open fissure? Our investigations, we never published that study, but it suggested, the just laying there for 10 minutes isometrically without doing the motion. It was the posture, not the motion, in other words, and that's much less traumatic to the facet joints. So there's an example of it was volume, and it was perhaps not getting the mechanism clear that it was the posture rather than the repeated dynamic motion that seemed to be the therapy.
And in that case, was that gravitation and the creep of the nucleus downwards with gravity? Or is that
No.
within the context of relaxation? Or how does that work exactly
Well, it
that
may
you're...
be in the context of relaxation, but consider taking an orange seed and I'm going to squeeze it between my thumb and my finger. If I bias the pressure or what's called a thrust line off center, the seed comes out that way every single time. So if you take a disc and you flex forward and delaminate the collagen posteriorly by repeated inappropriate motion and load, then bending forward creates hydraulic effort posteriorly. The floppy push-up reverses that posture and now creates a vacuuming negative pressure, and the nucleus tends to get drawn in. And you can watch that on video fluoroscopy or MRI. You know, we can take someone with an open fissure. It's easier to see it in the cervical spine than it is in lumbar, just for mobility and visualization. You can put them in an MRI scanner, and they may have a little bit of a disc bulge at C4, say. And then we will flex and bend their neck opposite to the bulge. So if the bulge is posterior laterally to the right, we would flex their neck to the left and anteriorly. The bulge will grow over 10 minutes. And then you measure it in the MR. And then you do the opposite. And you might put on a little bit of traction, and that disc bulge might be completely gone within 10 minutes. So it's very directionally driven, and you can measure that. So it was a function of hydraulic effort, not necessarily just gravity. But there's so many nuances I can layer on top of that. If that's only one little subcategory of disc bulge, if it's a disc bulge that started with a compressive overload and there's broken bits of end plate in the extruded nuclear material, and that's harvested in a microdisc surgery or even gross disc bulge surgery. What's been harvested out, in other words, the bulge, then goes for analysis. And this comes from the most recent work of Rajesh Karan's group, who won the 2025 Issels Prize as the top prize in the world in orthopedic spine work. And they found that if there was broken bits of end plate in what was harvested, plus modic change along the end plate, this reversal in hydraulic effort that I'm talking about and the ability to shrink a disc bulge, it really decreases. However, if there's not a lot of height loss and the end plates are intact, there's a really good chance for quite rapid reduction in the disc bulge through macrophage activity, etc. So do you see the layers upon layers of it depends, and knowing these various things really would guide specific treatments rather than just being random about it and say, oh, well, if you've got a disc bulge or back pain, do a floppy push-up.
May I ask a question? What is the demographic? Who are the individuals who may have an broken end plate? What is the mechanism that is popular?
Well, it's overload of compression.
Okay.
So many people will say, you know, the disc bulge really started with, I fell on my pelvis, I slipped and fell on ice. That would really damage an end plate. Excessive deadlift load. So they're not trained, they're not adapted, and they got far too aggressive in increasing the load in the deadlift with a trainer, perhaps. A good trainer really makes those progressions slow and working with Mother Nature to allow adaptations to occur to the bone. So there would be two, probably the most common scenarios, particularly when you live in Canada, or I would say in Prague, there's a lot of people who slip and fall on ice, and that is the beginning of the genesis to things that happen downstream.
The cobblestones in Prague are very slick.
Yes. Yeah. No, I know.
People walk a lot more than they're accustomed to, especially when they come as tourists. That's often what I see These people
Yeah.
go from sitting a long time somewhere in North America, all of a sudden they try and see the whole city in one go. The uneven surface, poor footwear, all of it feeds into it, which presents this kind of cascade of things which could be driving back pain. I'm considering what are the psychosocial aspects which contribute to back pain or nutrition. So then I will often refer people out, actually. I can have a discussion and help people identify the driver to their back pain, but I find myself needing help to really hone in on a certain aspect of it. And this is actually what Paul helps me with. And I'm wondering, to what degree should a practitioner, a chiropractor, or osteopath, or whoever else is trying to apply your method? And I myself have studied your work. I've gone to multiple seminars, but it still resulted that it's best for me to work with Paul, who is a BackFitPro practitioner. The question is, should people do your seminars and integrate it into their own practice as chiropractors, or are they better off seeking somebody outside of their own clinic, of their practice, or integrating a BackFitPro practitioner somehow into the equation?
The clinicians I've trained, and they've passed our exams and are BackFitPro clinicians, and you can see them on our webpage. I don't know if this is true or not, but I think most of them have a chiropractic background. I might be wrong on that, but certainly a lot of them do. And in the training to become a chiropractor is learning about stress and strain and movements and the results of all of these things. I don't know if a chiropractor needs to work with someone who's been trained. I guess if they have no knowledge of what we do, then that would be beneficial. But a lot of them take our courses and integrate their practice with science, I guess, that we can offer to help guide their decisions. In terms of the psychosocial, it's so interesting when you see a client that comes in and they are traumatized with their back pain to the point of having quite severe PTSD. And you will recognize these symptoms. You lightly touch them and they will flinch very inappropriately. They cower away. They are so fearful of that pain. You could do all kinds of cognitive behavioral therapies and those kinds of things to try and modulate that response. However, if you can perform the assessment in the way that I'm describing as a troubleshooting exercise, the person will learn very quickly what causes their pain triggers. Now, if their pain is caused by laying a certain way or sitting a certain way or walking or throwing or whatever the activity is, and then we can break it down into very specific motions, postures, loads, durations, rest periods, etc. They understand that they now can master their pain. So prior to, they would be walking down the street and get a massive shot of pain and not know the mechanism. That's traumatizing. That's a bogeyman that jumps out of behind the corner of a building and hits them or puts a knife in their back. It's terribly psychologically and sociologically traumatizing. But once the person masters a way, a strategy to prevent that, or to know what to do immediately if they do have a trigger, that pain stops producing the PTSD and it starts creating an empowerment because they can manage it themselves now. So the next time they get pain, they just say, oh, I learned. I offended the pain trigger and I know how to fix that now. And now their PTSD starts to wind down and that psychological reaction. So again, it is understanding with mastery the pain triggers. You could do that in your office. Do you need a psychologist to do cognitive behavioral therapy and the person continues to create the offense that's causing the pain trigger? Or do you educate the person as to what that trigger is? Now, that's a decision for you. It's an it depends question again. But I don't know. Once the clinician has been trained, certainly. I mean, I will on occasion use outside help for heavily traumatized people. They have such corrupted engrams in their brain and some real disorders. And they might be very specific neural branch and pathways. And there are better experts than I. So we will go out once in a while as well, but maybe not as often as you or some of the other clinicians think it's necessary. So that's part of the training, I guess.
I get it. What I was referring to mostly is not necessarily an individual that's traumatized by the pain, but there may be an aspect of their life, let's say divorce, let's say some other kind of trauma that they might be carrying, which might be feeding, standing in the way from them actually healing. Whether that is contributing to the pain or not, one will only know once they're kind of given the appropriate help.
Let's take a person who comes into the clinic and they are going through a heavy divorce, and that pain is in their body. You can see it with the stiffness in their body. Fear stiffens, anxiety stiffens. We get all of this. It literally is crushing their body. When they walk, they are overloading themselves. If they were taken through an appropriate relaxation protocol, and then you could start to allow them to, okay, they do need core control. We get that. That is a certain strategy for stiffening, but then unleash their shoulders and their hips. And this would be all part of the movement therapy done in your office, and then go outside and translate that to walking down the cobblestones of Prague. Now we have given them a tool that, of course, the anxiety of going through a heavy divorce is one thing, but you are directly addressing the downstream effects on their joints and their body that is all part of their pain pattern. So now instead of fighting Mother Nature, they're working with Mother Nature. So I'm not saying the psychological is completely an independent variable. It's something that sometimes you can cure it in the way that I've just described, going through a daily relaxation practice and translating that to real life. Or they may need some real heavy psychological intervention, and we get that.
I get it. So a well-trained clinician should be able to spot these patterns, help the individual identify the drivers to their pain, and then show them what it is that they can do. I think one of the challenges getting people to do something consistently at high quality, and what I found is if they have an appointment with somebody who can help them, walk them through the process. And I have a trainer once a week that I see for this exact reason. It just helps me to hold accountability and show up. I think that's the best way forward.
Well, it is for you, and
Yeah.
it is for a lot of people. We get that. That's, again, it's a depends thing. That's really necessary for some people. And I will say for some very high-powered people as well that I've met in this world. They actually travel the world with their team. That's how important it is to them to keep them functioning at a high level.
Well, something might help the pain when it's at its worst, but then when it's not very painful, a human being just loses that motivation. And they might have the book at their hand, an online program or a YouTube video or a Reddit post, but in the end, having an appointment somewhere is very valuable. People even ask me if I can offer a service where I send somebody to their house just to make them do what they need to do.
May I put a little bit of a button on that?
Go for it.
Please.
Consider all the health systems in the body, the musculoskeletal system, the endocrine system, the cardiovascular system, the psychological system. Every single one of them for optimal health requires stress. Agreed? If they're not stressed, they're weak, they atrophy. However, the applied stress has to be below a tipping point, because there will be a point where more stress actually now causes a catabolic response, not the anabolic response we all are after. So that tipping point really needs to be managed, and it's continually changing. Now, let me ask the question. Consider the full rubric of healthcare. There's surgeons, family doctors, all kinds of specialists. Who in that whole spectrum is responsible for stressing the body? It's the trainer. It is the person who organizes their daily training that has by far the biggest effect on their long-term health span. So I hope you get that right, everybody. And I hope you choose a trainer who is expertly knowledgeable, understands all these systems, understands training volume, understands assessment, how to find the tipping point, how to feed your body what it needs to get through in its most resilient and high performance state over the full health span. So there, how's that for a statement? What you do is the biggest determinant of that person's life.
That's fantastic.
Wow, no pressure. That's a short
Well,
list.
yeah, no pressure. It's a hell of a pressure. And it's incumbent upon every person to keep seeking the level of mastery, as you do. I know you do with continual education for yourself. I've been on this planet just about 70 years. I'm still working on trying to seek mastery because of the tremendous pressure I feel to get it right for every person who comes to me for health, or we try and send to you in Europe.
I love that. I love to hear that. That's great. So when they do come to you, speaking of finding their trigger, their individual trigger and the assessment process, could you take us through a little bit of the McGill method assessment? One of the most powerful pieces is identifying the exact mechanism of pain and the corresponding position of repose. Is this why your methodology is effective? I think this is the real critical piece for myself. Can you speak a little bit to this and maybe also explain to us why you spend about 3 hours with somebody when you assess, while most medical consults are about 20 minutes?
It's not that I spend 3 hours assessing a person. I may, but again, it depends. And let me give some cases to illustrate the spectrum. I can listen to a person for 5 minutes as to their history. I watch them walk into our clinic here at BackFitPro. And after that 5 or 6 minutes, I have a pretty good idea and I have a fairly high degree of certainty of what's going on. The next person comes in and they've already been to a dozen different clinicians. They've already been to the psychologist, the surgeon, the chiropractor, the physical therapist, the massage therapist, the yoga master, etc. And they all failed. So what would then take me time is to go through those and find out what were the roadblocks, or why did they fail? What stopped them to respond? Then I may have to perform physical testing, and you know all the tests. You've been trained in them, where you systematically go through the movements and create commonalities of what makes them worse or what makes them feel better. And then you test specific tissues, the facet joints, the sacroiliac joints, the disc itself, and all of its glory and inflection, and is it an open fissure, and you keep subcategorizing it down, and then you realize that, well, when they move, it isn't that the joint is rotating as it should. It rotates, and then somewhere in the midpoint, there's a little bit of a shearing clunk. Oh, that's why I get that shot of pain, a movement catch that takes my breath away when I step off a curb or get out of a chair, and I don't do it with care, and they trigger that. But, that takes maybe 45 minutes to sort out. And then I'll go to the end of the spectrum. And this was a client I had somewhat recently. And in my first assessment of them, it was clear they had these micro movements that I'm talking about. And with uncontrolled movement, they would move. They would have a flash of sciatic pain, and it felt like a knife going in their back. And we understand all that, and we're able to show them techniques to wind down those sharp triggers. But what we couldn't understand was I would pull on the nerve roots, the femoral nerve roots, the sciatic nerve roots very precisely, and we couldn't find a specific nerve root tension or friction that caused this very specific radiating pain down their leg. But I did notice one thing. I moved them a certain way and they recoiled. Do you remember that traumatic PTSD characteristic response, and I just made it in my notes, but I never put it together. I usually will do an assessment for a client, and their medical team comes with them in the appointment, and I train the medics or trainers or whoever it is, or I will then pass them off to one of our BackFitPro people, you being one of them. But things weren't changing with his radiating pain. Clearly, I was missing something. So I didn't blame the patient and say, well, you're manufacturing your pain. It's in your head, as all the clinicians who reached the same roadblock did to him. Instead, it traumatized him. He was starting to believe he was crazy and all the rest of it. But that's not what we do. We keep working until we find the specific pain pattern. Non-specific back pain does not exist. It's always specific. It then took me a while to realize that he had a myofascial syndrome going on. And when the fascia was stretched a certain way and we would pull on it and create spiral lines of tension, and that very specific friction under that tension would then create this radiation. And his brain had been rewired to create a maladaptive response to that biological trigger. Now I'm starting to understand why after a month, the pain still isn't moving. So at that point, there are a few options on how to treat that myofascial pain, and some of the psychological cognitive approaches work with some people. Sometimes you brutalize them with exposure to ever increasing loads, and they're supposed to adapt to that. It's called work hardening. Sometimes that works, and sometimes it deepens the PTSD and the maladaptive myofascial response. And these things had been done to him, and he was only even more traumatized. So what we are in the process of doing is teaching his brain to have the appropriate response to movement. Do things that don't trigger pain. If that's all you can do without triggering pain, that's all you can do. Teach the brain to perceive that as a pain-free movement. Then you start to add nuances to it, and then you start to work through the body. And it's a slow process, but that would be an assessment now that has gone on for over a month. And I'm still learning the nuances of what is making this person's pain. So there's an example from a 10-minute assessment to a 45-minute assessment to a 3-hour assessment to a month-long assessment. And by the way, let's get back to our medical colleagues now. I mean, truth be known, what profession teaches about back pain? I don't know of one. The full spectrum of our medical colleagues do is they are trained in a specific approach. A surgeon has a knife. A chiropractor has manipulation. You know what I mean? Everyone has what they've been trained to do. And then there's a billing code for what they can bill for. So when a person comes in with non-specific back pain, they will get from that medic what they've been trained in and what they can bill for, whether or not it fits the specific back pain they have, because they don't have non-specific back pain. So now the whole system works on luck. Will a manipulation address the cause of this person's pain, desensitize them, and get them on their way? Or will a knife do it? Or will ablation therapy or sound therapy, whatever it is, it's luck. That's the difference. The assessment with us is a troubleshooting investigation, and we take the time that it takes. End of story.
I need to say something on that point is here in Prague, we don't have the billing codes because for the services Paul or myself offer, we don't, they're usually not covered by health insurance. So we don't have that limitation, but maybe this is just specifically to us, but I understand what you're saying. I wanted to ask you about not picking the scab, but I think you kind of outlined it with this case, and maybe you could say something more on that matter. But before we do, if I understand correctly, you helped that individual with the myofascial syndrome understand the parameters of where they are and where they need to be for a certain amount of time in order to be without pain. And then you kind of venture out and build it out once you learn more. Is that correct?
I don't know if I would use those words. I think that's correct. To basically
In
find
my
what movements they can do that doesn't trigger pain to teach their brain appropriate responses. And as the pain winds down in sensitivity, it will present a more opportunity to expand the movement repertoire, which you then change and include that and keep it going.
We're talking about not picking the scab, basically the phase one of recovery, right? So once we find the pain trigger, we work to avoid picking the scab, and then we, as you call it, while building resilience around the injury. Then there's a phase two, because no pain doesn't mean healed. We all know. At some point, the symptoms will disappear, but that doesn't mean the person's healed. So this phase can be quite dangerous if someone's reverts to poor movement habits, for example, and we've seen that many times over. How do you approach this transition phase where we begin to build robustness and movement competency against the very mechanism that originally caused the injury? In other words, how do we know when a client is ready to enter the second phase, and how should programming evolve accordingly to this? I think what I'm trying to say is that people often misunderstand your methodology by seeing one phase of it. So perhaps you could speak to how this approach changes as the client changes and as they evolve, as their case changes, their resilience, their movements, and time, of course, is a factor as well in their healing.
Well, there's three questions there is what I counted. Yeah, people misunderstand the McGill method. If that's true, which I would say is broadly true, it's because they haven't done their homework. I was a professor for over 30 years, and we ran the experimental research clinic, seeing real people. And I ran several laboratories. But through all of that, I was trying to create 6 pillars of evidence. We did in vivo work trying to measure stress on the various tissues in real people, because it's stress that creates tissue damage and injury and healing and everything else. It's stress and strain. We loaded cadaver spines to get a 1-to-1 match between a mechanical insult and a acute change or damage. We had a radiology suite where we would use various ultrasounds, CT, X-rays, etc., to try and match what the feature was on an image and a person's pain. And we know why sometimes there's concordance and sometimes there isn't. An MRI, for example, it images features, but you need to assess the person to know whether that feature is a wound that's causing pain or an old scar that's now just a scar. It's a feature, it's still there, but it's not causing pain. So when people understand that, now they don't have to have discussions on whether MRI is concordant with a person's pain. It's the assessment that will show you that. And then in the experimental research clinic, that's where we tried and trialed, and we measured the outcome of every single patient we ever saw. I don't know of another lab or clinic on this planet that follows up with every client to find out how well they did. So we know precisely what subcategories of pain, what interventions worked. We know the clinical score exactly. We did epidemiological studies. Specific back pain forms around clusters of sport. Why do rowers get a certain type of back injury, and why do some rowers have bulletproof backs? They row their whole lives, flexing over and over again and never get back pain. What is the distinguishing feature of those? Versus, they say, well, a posterior disc bulge is the rower's disease. Well, it's a high incidence, but there are some people who are absolutely bulletproof. For why do certain occupations have high incidence of certain types of back injury? And then we did clinical trials. We ran trials on firefighters, police officers, military units, etc., to see what worked on a group scale. Anyway, people don't know that. So they will say, oh, well, McGill just did this, and they'll dismiss it. But that's their ignorance. How do you know when a client is ready to enter a second phase? Well, it's when life doesn't cause pain and the clinician guiding them reassesses them, knows what the new goals are. It's not pain reduction anymore. It's creating a resilient and a high performance, we'll say body, but I would say much bigger than that, a human system. And People say, oh, well, all McGill does is the big three exercises. Wait a second. We've restored careers of some very high profile athletes, not some, hundreds in virtually every professional sport, every Olympic sport, sports that are neither, like powerlifting, for example. It's not an Olympic sport. It's not a pro, well, not really a pro sport. We've managed their development back to, in many cases, setting not only personal bests, even before they were injured, but world records. I don't really know how to answer the question except to give that broad statement. How do you know when to progress the person? Well, you should know through the assessment. And is it possible to get them there? Yeah, use the right technique to reach the goal, whether they're an elastic speed athlete or a strength power athlete or, a game savvy athlete, whatever it happens to be. You've got to know all of that. And, I'll say this. How many car mechanics are there in the world? Hundreds of thousands. How many can build an F1 race car that will win an F1 race this year and next year and the year after? Probably a handful of people in the world. And unfortunately, it's the same in the clinical world. The average person can't handle the breadth of what we do. It's arrogant to say, so they'll dismiss it. But those who can have much higher rates of helping the broad spectrum of specific back pain to people that come to see them.
I guess what I was trying to allude to, or what I was trying to point at, is that different rules apply in those two phases of rehab. So whereas in the first phase we try to wind things down and we try to be very conservative about the pain mechanism, train around it to build robustness and general sense of strength. In the second phase, we want to almost go directly after that mechanism in order to support it becoming more resilient at times. So I guess I'm just trying to get clear on, is it a distinct phase where we've retested and we've set new goals and we've talked to the client about it, or is it something that can happen suddenly or gradually? I've seen the whole array of situations where I was expecting that rehab would take a number of weeks, and a couple of weeks later, the person's doing really well, pain-free. And I'm wondering, should I be adding load? It seems too early, and so on. So I'm just thinking, are there any main parameters or any boxes to tick before you allow a person to actually expose themselves to something that would otherwise exacerbate the very trigger? Is it time? Is it just their state? Is it all of the above? What would be the main parameters that I'm looking for?
I can't give an answer to that, Paul. I'm sorry. Until we have the individual standing in front of us. As you were saying that, and I'm down here in BackFitPro HQ, and I'm looking around at the walls on some of the very high performance athletes, and I'm looking at one from the UFC. And I know you're a combat sport specialist. If I had a combat athlete in Europe, I'd send him to you. Having said that, here he was in the UFC, a very decorated veteran, very skilled at stand-up striking combat. He's also a very skilled jiu-jitsu practitioner, which is ground fighting, basically. And when you're on the ground, you adopt a guard, which is heavy hip flexion and heavy spine flexion. But he had a posterior open fissure disc bulge. He actually had that attack him in a fight one time. It's not a nice place to be because lethal, very, very bad consequences. But anyway, he never reached the point, even though he had such a storied career, where he could just transition to a lot of mat training. He would have to restrict the exposure of the mat training because the open fissure was there and the disc would start to bulge if he did too much guard training. So what we would do, we would be very judicious in his training to avoid that mechanism because he wasn't going to adapt it. The disc had flattened, the nucleus had now turned to, it wasn't a nucleus. You can adapt bone, you can adapt an end plate, even with a heavy fracture. It's very difficult to adapt type X collagen. That's the collagen that binds the type 1, the strength collagen, and type 2, which is the elastin collagen. It binds all those fibers together. You can adapt mobility with playing jujitsu, but then it's very difficult to also adapt high load bearing. because what gives mobility, the softness and the compliance, but you need stiffness of all the fibers to hold the pressurized gel in behind. So you're telling the body to adapt in two different directions and it won't do it. So you have to make some decisions there. So in his case, we never got to the point through his whole career where he could just train jujitsu at will. It had to be very carefully controlled, and it was only to hone the technique and remind his body of, okay, there's the move, you've got it, good, that, and save it for the octagon, in other words. And there are a lot of veteran athletes in many different sports who have to save certain elements of their training for the performance of the sport.
Got it.
Any trainer can take a young 19-year-old athlete and get them to perform well because they heal quickly. You can make mistakes. They're really adaptable. But after they've got some miles on their body and some existing injuries, a whole level of expertise is now required. And you're asking me for what are the metrics, and I can't give them to you until we have that individual person in front of us and we know the person and we know what their training volume is, we know what their specific triggers are, and we noodle our way around it. Let me see if I can come up with a better example. There's all this discussion about the Jefferson curl. Well, I'm one of the few guys who've actually measured the mechanics of what's going on in the Jefferson curl. And if I may, so it is such a unique exercise in that the person segmentally flexes their spine one segment after another. That is about the best way to recruit and challenge the multifidus muscle. The multifidus activates segmentally if you extend L5, but not at L4. The multifidi at L5 are active, not at L4 and L3 and L2. And you can just measure and watch multifidi up and down the spine. Well, okay, that is a fabulous activator and training of the multifidus muscle. Fantastic. Now take a person with an open fissure disc bulge. It is that exact movement that causes sciatica or some other symptoms, so they can't do it. But wow, the Jefferson was the best way to challenge the multifidus. So we hack our way around it, working with some of the strongest man competitors and seeing how they do it. They might go over a end of a bench and do a little bit of a micro extension and then cantilever out of the bench a little bit more and systematically work up and down the spine, challenging the neuromuscular compartments of the erector spinae. It's exactly what we see when Glasnost happened. And I went to Poland and I went to my colleagues at the scientific meeting went to go and sightsee. What did I do? I went to the scoliosis clinic to see how the Poles were treating the young girls with scoliosis. And I saw exactly the same exercises, challenging the erector spinae up and down the system, trying to capture the different neuromuscular systems. It wasn't a Jefferson curl because they couldn't tolerate it. So they took the benefits of the science of what was learned about segmentally curling the spine and then created a hack or a modified exercise, a very short range exercise that achieved the same goal.
So it's short, basically, right?
Yeah. So, a good trained person will know how to transition a person when they get out of pain, recognizing their past very specific injury history and work with it and hack it and know how to program it. And sometimes it's an experiment and error. I don't know. Sometimes I will say, well, let's try this and let's see how your body responds tomorrow. Did it like it? Or did you get a warning signal that that's not for you? So it's a back and forth. And this is what I'm afraid the social media crowd doesn't get.
Take things out of context. I think exactly what just happened here. I asked you a general question and you tried to give me a very specific answer because the only true answer or exact answer is a specific case scenario. So I appreciate your efforts in that. What I'm hearing as an answer is, again, programming and the dose being the poison. So those are the main things that we're looking at when treating that person. And then you basically said that in principle, it's not the problem with the exercise being the Jefferson curve, for example, but rather the application of the lever perhaps for that individual who wasn't ready for it. So thereby those clinicians you spoke to were able to somehow shorten the lever or adapt the exercise in order to get the benefit out of it, but not expose the person to that level of risk. So that all makes sense to me.
I know.
Right.
There was one point when you were speaking about some stories, Professor McGill, with the athletes and so on. Can you give any examples where a seemingly minor tweak had a massive impact on someone's pain or performance? Anything that really sticks in your mind?
Well, we've just been through the Olympics
Yeah.
in Italy, and I know intimately a few, and there was hundredths of a second between the gold medal and fourth place. So a tiny little tweak had massive consequence.
That's a great answer.
That's an example
Can you
right
say
there.
what the tweak was?
I can say this, and only because it's true. Some athletes are treated by strength and conditioning coaches who don't know their sport. So they were given very, very high volume and heavy deadlifts and squats to do because they needed very powerful hips for this particular sport. And disc bulges were higher than they should be. I cannot take that athlete and use a squat or a deadlift now because their spine won't tolerate it. And yet they're one of the best athletes in the world at that particular sport because it requires tremendous leg extension, speed, power, and control. What we did was, one machine that we would use, we're in BackFitPro HQ. If you look over, if I can get my finger on it here, there's a belt squat machine right there. And so the athlete would then get into that position and have the belt on with, several, 100 kilos of load, which is a good load. And then they would squat back into the position. They could get into all kinds of spine deviated positions because their spine wasn't loaded, but they needed hip and leg horsepower. And we would do piston squats up and down and then start working down into the range over here, little short piston squats to develop the power development throughout the range, taking advantage of their hips and not going near their pain trigger. So there would be a hack that it got them operational and back to Olympic form. So I don't know if that answers the question or not, but there's just an example of, they couldn't do a barbell on their back kind of exercise or even in their hands. But it doesn't mean they can't compete at the Olympics, if that answers the question.
Would you ever use that technique? Let's say, let's take the example of an alleviating position. Let's say lateral flexion with slight rotation to the right, taking the pressure off of a nerve on the posterior lateral left side. If you were to get into that kind of position, which is alleviating, would you ever in that context consider training the person's legs just to kind of maintain their lower body capabilities while you're going through the rehabilitation process? Or is that no-go in terms of mixing and matching?
If I understand your question, Paul, of course we understand the full linkage. So let me give an acronym here that will guide a lot of training. The knees will go where they're commanded to go by the hips and allowed to go by the ankles. So let's say they have a knee deviation, and that's not only part of their knee pain, but it's part of their back pain linkage. We need more knee control. And how do you get knee control? The knee control comes from what the hip is doing. The hip will organize internal, external rotation, varus, valgus, etc. But the hip cannot do it if the core isn't controlled and stabilized. Now we have to work through the linkage. We need a stable core to allow the hip to be the athlete, to control the knee. And if we were doing squats and leaning over to one side and they can't go any further because the ankle won't allow it, I might put a centimeter of a heel lift under their heels. Now I've taken and hacked my way around the ankle restriction to allow the hip with a controlling core to direct the knee. And that solved their back problem. So there might be an example. Yeah, you've got to think through the linkage and you've got to know how this linkage works.
And I'm guessing same logic would apply as to the McKenzie extension at that point, right? Do this for a period of time until the situation changes and discontinue, move on to something else.
Sure, I might do all kinds of things to increase the hip athleticism in controlling the knee, and I might do some kind of a stretching program, or maybe they just have a stiff ankle because it's the legacy of being broken. I have to hack my way around a formerly broken ankle that isn't going to move anyway. So what can we do?
I have a question, which is I imagine the people you meet before they come and see you, they will have maybe read your book, The Back Mechanic, and they will have attempted to implement some of what they have learned. Are there any common misinterpretations that you've maybe seen?
Well, worse yet, they've gone to the internet and they've seen someone pontificate, oh, well, the McGill's method is the big three exercises. So they think that doing the big three will help them. And I'll get a letter from them, an email. Dear Professor McGill, I've been doing your big three exercises, but I'm not getting better. And my brain thinks, what are you thinking? What would possess you to think that well, it does help a lot of people, there's no question, and there's several reasons for that. But it doesn't help everybody. More importantly, it may be that they sit on a soft, floppy couch watching the television for 2 or 3 hours every night, which undoes all of the good things they're doing throughout the day. They keep causing their pain while they are mitigating their pain through other behaviors. So they can read back mechanic, or if they're more complete in their efforts to understand their pain, they would have read Ultimate Back Fitness and Performance, which is now you're out of pain. Now let's train and put it together in a way to enhance some performance capability. Or maybe they're interested in preventing the cause. Now you've got to read Low Back Disorders. In other words, each book has a unique theme and information set to it. They don't get what the McGill method is, particularly if they just learned it off a short little YouTube thing. But if they can get it and put it all together, now they're much better equipped to know how to A, wind the pain down, B, build some resilience, C, do all of the things in life like picking their child out of the child carrier in the back seat of their car, or you can't sit on that couch and watch TV for 3 hours and expect to get your back better. It will not work. You're pushing rope.
This is great because you just mentioned, that we just touched upon the big three and ultimate back fitness and performance. And I have a question actually relating to the big three. Naturally, given your wide arsenal of tools, as shown in the Ultimate Back Fitness and Performance book, why have you chosen the big three as the foundational exercises for so many people? What criteria specifically guided that selection? That's what I'm really interested in.
I'm not avoiding the question. I'm going to answer it, but I can't answer it without establishing a very important context. May I do that? Okay.
Please.
So I have to go upstream one level to answer that question. We live in a linkage. The performance of this linkage depends on strategic stability and mobility. You can look at any linkage you like. A backhoe is a linkage. Until you establish proximal stability of the tractor part, you can't dig earth. So you have to put down stabilizer bars to hold the proximal tractor stable that now unleashes the athleticism of the shoulder joint, the elbow, and the wrist that drives the bucket. You get what I mean? We must establish exactly the same strategic stability and mobility through the links of the system. The spine's a flexible rod. It's got a ball and socket, so very strategically. At either end of that is a hinge joint. At either end of that is a wrist and an ankle, all with serving specific purposes. So when you strategically get the stability and mobility right, the system dissipates stress concentrations, becomes much more resilient, and it performs at a much higher level. Try and lift with a wonky core. Things aren't going to work out for you. Try and run really fast. You can't drive your thigh if you can't develop proximal stiffness to get the athleticism of the hamstrings and the quads and the gluteal muscles to drive you know what I mean. So now with that background, I can answer the question. A lot of people don't have sufficient control of their core or fitness of their core to meet the demand. So then I had to ask the question, what is the best tool that we can find to establish core fitness in an endurance profile first before strength, because people with back pain tend to have less endurance, much more so than less strength. People are surprised to hear that. We have to guarantee stability from the exercise. We have to do it in a spine conserving way because load is currently exacerbating of it. And we have to prescribe it on an isometric endurance protocol. The best exercises that kept bubbling up to the top to meet those goals is the bird dog, the side plank, and some form of abdominal stimulation, whether it's a modified curl up or a plank or whatever. Those are nuances depending on the health of their shoulders and, hips and all those other things. So that's how we converged on that. And then we did the clinical trial work. Does it work? And then after trialing it, yes, it worked better than sit-ups and, Roman chair hip flexions and all of these other things. So that's why we converged on those. That's why it's the foundation for many people. It's why a lot of elite athletes still, even at world record performance, still start their warm-ups with a few bird dogs and perhaps a side plank, etc.
That's a great answer. I just wonder what specifically is superior about the bird dog as compared to a Roman chair exercise?
It depends on the criterion. If we take load on the spine, Roman chair extension, both the thoracic extensors and the lumbar extensors are active to support the whole cantilevered upper body. In a bird dog, it's not a cantilever. It's a three-point bend. You are on your hands and knees. You can control the posture as to what is the most pain-free posture, whatever level of lordosis you like. And then by extending one arm and the opposite leg, only half of the musculature is activated, the right upper back and the left lower back. So it's half the load on the spine that is in the most tolerable posture you can find. Now we can get into what are some of the other mechanisms. We know, for example, let's do an assessment. Let's ask the pained person, do a 10-second bird dog on one side with perfect form. Don't lift the leg, push the heel away. Don't lift with your back. Stabilize your back and use the glutes and hamstring to push the heel away. Changes the game. Then repeat it. So now they've got two 10-second holds on one side, do two 10-second holds on the other. Good, now stand up. Tell me about your pain. Oh, it's gone. Okay, fantastic. We just found a way to mitigate your pain. Now, how long does that last? Oh, lasted 20 minutes. Or in some people, it will last 2 hours. Now you have to ask the question, why? I thought it was because you're training the brain now to, and I personally feel a little bit of a stiffened, controlled core, not a wonky core, after doing those exercises for some time afterwards. And if I do the mid-morning and mid-afternoon, I'm moving well. I'm feeling very fit. But that was my own perception, and I really never was able to prove that. Recently, there's a professor quite popular on podcasts. Have you heard of Keith Barr from UC Berkeley? And Professor Barr is an expert on collagen fibers. And what he's found is that when you do isometric exercises, it squeezes out the inflammation and reduces pain. Could this be happening with the discs of people's backs? Don't know the answer, but I think I will know the answer if you ask me that question in the future.
That's great. So to recap, what I'm hearing is basically the minimal effective dose and a conservative loading profile is what makes the bird dog superior, essentially. That's what I call it.
Yeah, and you have to coach the bird dog itself. Some people, there's people who say, well, go to the internet and look up how to do a bird dog. There's only one or two YouTubes that I've seen that I would say that person knows how to coach. Why have I not put out a YouTube on it? Because I don't know what the form is until the person is in front of me.
And I guess that's another question that you just segued into, because I guess what we're trying to do sometimes is we're trying to do things at scale where we're trying to find the common denominator, the commonalities that help most of the people most of the time, so we can give some general advice at least. And so I wonder, in your opinion, is there ever a place for general preparation or universal movement that works for most people most of the time, or is it always a one-off specific case?
Well, I could answer that both ways, and it's not to avoid the question. I'm trying to answer it. Let me start by saying, okay, I wrote the book Back Mechanic, which was the one I wrote for the lay public. My other books were for coaches or medical clinicians or. So I wrote it for the lay public, and it was the hardest book I ever wrote. I
Mm-hmm.
had to make it simple, and I had to make it broadly applicable, knowing in my heart that it would help 95% of people, which is, I followed that up. I'll stand by that number. But it didn't help 100%. No book ever will. So there is an example of a general approach, not knowing anything more than they have back pain. Now, in the book, I take them through a self-assessment so they can subcategorize their pain into specific pain somewhat. Is it as good as a clinician? No, it isn't. We know this. So there would be an example of a general approach with its restrictions, but it's not until they have been with a skilled clinician that they will get better outcome. Even with the very best clinician in the world, do I have 100% success if you want to put me in a category of an elite clinician? No, I don't. So all of us striving for that. And then, at the end of the day, you say, well, man, just some things can't be fixed. Well, I've heard that, and I have seen some sad cases. Anyway, let me then go to a scientific principle that you sitting where you sit can use. And I will use this myself. You take a group of people and then you ask two questions. Are you fit and do you move well? Forget about pain. They don't have pain. Are you fit and do you move well? Yes or no? Now you've created a 4 square box. Are you fit? Yes or no? Do you move well? Yes or no? Right? So if you're unfit and you don't move well, you're in this box. But if you're fit and you move well, you move in this box. If you're fit, but you don't move well, you're in this box. And if you're unfit, but you do move, in other words, you get what I mean. You've got the 4 combinations. So now you have a person who's really fit, but they don't move well. What are you going to program? More fitness on bad movement patterns, creating stress concentrations where you're going to end up with quite possibly you've certainly increased the risk. If they're falling into knee valgus, you've really increased the risk of ACL injury. You know that. If they're into heavily deviated loaded flexion, you're risking the risk of a disc bulge. Every single study has shown that, whether it's epidemiological, whether it's on cadaveric spines, whether it's a clinical trial, as we've done on different people. Why do some people on a particular team get this? When you look at their training profile, it's pretty clear to see. So now you've got 4 boxes. If they're moving well and they're fit, you can have a lot of fun with your programming. Sky's the limit. But if they're not fit and they're not moving well, I suggest you get them moving well and then you get them fit. But if they're already moving well, but it's just their fitness that needs attention, you can now focus on their fitness. So do you see how there's a sort of a general, simplified, general preparation guideline to, again, subcategorize quite simply, but it's so effective.
So that would be the demographic component. And then in terms of the elements, how would you categorize the elements that are most important for rehabilitation of the back? So back pain specific. What elements do we need? Which boxes do we need to take in terms of
Well, if they have pain, number one, you've got to desensitize the pain. But now we need to know what is the specific source of their pain. What's their injury history? What's their body type? Who are their parents? Is there a psychological element? What's their current tipping point? What's their job? Who are they responsible for? If it's a parent who has to work to support their kids, otherwise their kids aren't eating, and the job that they have is hurting their back, you've got a roadblock. They won't get better. So you need to hack your way around that. I've gone back to work with people to their job to see what we could do. If they sit a lot for their job, there's a lot of things we can do. If they have to pick parts out of a parts bin because they're assembling a chair on an assembly line, can we arrange that layout of the job in a way that doesn't create the very specific stress concentrations that trigger their pain? Or can we train them to be more resilient in their hips and their knees and their shoulders to de-stress the stress concentration that's hurting their back? Or again, whatever the case may be, more exercise might not be better. Or it may be this person is sedentary. We better give them some exercise to make them even more. Do you get what I mean? They're under exercised.
Sure.
It's desensitize the pain and then do whatever you can to make them more. And that's different for everybody. But
Sure.
at least
So
if
it's
we
programming
know that,
meets individualization in order to build out the program and the do's and don'ts in that given phase of training.
right. That's why you're employed. That's why you have a job. That's so important to do.
I would like to ask, is a poor breathing pattern considered not fit or does not move well? As the diaphragmatic kind of stabilization pattern, and it's something we haven't touched upon, but maybe this could be a segue into it.
Oh, yeah,
All
you
right.
just jumped into my question. So maybe I can just skip ahead to my question because this is pertaining to this as well. Specifically to breathing and diaphragm and the spinal loading. Many assume that you actually don't emphasize breathing mechanics, but I know that's not the case. I did read the literature. Maybe you could speak to what you found while you were studying the diaphragm and its effect on spinal stability and compressive load specifically. Where does abdominal breathing fit into the hierarchy of importance for you, especially in early stage rehab? And are there even more critical factors? That's something that I've been wanting to ask you for a long time. This is one of those things that people, throw around on the internet. They'll say McGill does this or that, McGill Big Three, Kolash diaphragm, just these very, very short answers that are not as nuanced and not specific as what we're talking about here. But I do recall that you've done some specific studies that pertained to the effects of the stabilization, diaphragmatic breathing, intra-abdominal air pressure, and then also pertaining to the conical shape of the torso, that there was some effect there.
What my answer is going to be to start and is it depends. If we get into specific instructions, we need the person in front of us, but we can talk some generalities from our scientific investigations. For example, is yogic diaphragmatic breathing good? Someone will ask that. And my answer is I can answer yes or no, depending on the context. If I need to get a person ready for the NBA to play basketball, diaphragmatic breathing is probably not going to translate onto the court. If you have to box out, well, Shaq O'Neal doesn't play anymore, but someone who knows how to do jujitsu under the basket standing in the key, you won't move them out of the way with that kind of breathing. But if a person comes in and they are wound up short, and you can just see that type of breathing with the fear in their body and the pain, to take them through a yogic style of relaxed breathing, controlling their body with breath and systematically releasing the muscles. Now, my daughter, Sarah, is one of our clinicians. Her clinic is called Spine and Spirit. And if I get that kind of a client, I just send them to Sarah immediately. She's just down the road. And that is the most appropriate start in that particular kind of breathing pattern where the tension is just loading their spine. But it's not going to work for a power breath of throwing a shot put. It's not going to work for when you have to take a good amount of air in your lungs, lock it down, drive all the slack out of your body, and pick 100 kilos off the bar in a deadlift. That's a totally different breathing pattern. So
Sure.
do you see what I mean? Do you hold your breath? How much air do you take? Do you pulse when you're power breathing? How much stability is required? How much romance do you need to quieten the nervous system down? And belly breathing or yogic breathing, whatever you want to call some of these different styles. There's a huge variance, but we studied COPD patients. Almost all of them were ex-smokers. They'd lost lung elasticity to breathe. They now had to breathe with their spine. they have a high incidence of back pain because how they breathe, they've lost lung elasticity. So the diaphragm, being a hydraulic pump up and down to pull air in and out of the lungs, isn't going to work anymore. That whole system has turned to inelastic leather. So to breathe in, they have to extend their spine. And to breathe out, they have to compress the air out. So now, as they're breathing with their spine, you see why they have most of the time thoracolumbar junction back pain, severe. So do you see how it is so nuanced? But you have to understand the mechanics of breathing and what all these different things to do. So that's why we try to investigate the different types of breathing or ventilation. A pulmonary physiologist would say it's not breathing, it's ventilation mechanics. But anyway, to try and understand those, and a couple of our papers were written with a ventilatory physiologist, Dr. Mike Sherritt, as you will see in our literature, to try and understand some of that. So, we talked about translating to sport, power breathing, trying to relax people who are too tense. Some people are saying, oh, you have to do a Kegel to help the breathing mechanics. And then they say, okay, now go sprint 100 meters. Really? Sucking up your pelvic floor? Try that. Anyway, now, did I just say there's not a time and a place? No, I didn't say that. I'm just saying for a good clinician knows when the time and place is for understanding all of these different breathing ventilatory mechanics and how to optimize, as I keep coming back to, optimizing resilience and performance. Get the stress concentrations out.
I suppose it comes down to semantics and definitions, right? So when we say diaphragmatic breathing, what do we actually mean by that? Are we talking yogic breathing forward and back in a wave, up and down? Or are we talking inflating circumferentially and expanding in all directions in order to create that conical shape of the core, right? Which would then help or aid the stability of the trunk as you try to load the front, the side, and the back, and so on. So I guess I'm speaking to that kind of athletic inflation of the diaphragm being said to help. But I also recall in your work that there is a compressive price to be paid for that. So again, we're talking about some sort of U-shaped curve in that respect.
I think I know what you're referring to. Years ago, we talked earlier about the eras that are in therapy that they go through, and there was an era where it was very common to hear about, oh, you should build up intra-abdominal pressure for your back pain. Well, let's go through the mechanics of a Valsalva maneuver. To do that, you have to activate your respiratory muscles, activate the abdominal wall, and squeeze to build intra-abdominal pressure. And the theory was that creates a hydraulic vessel that pushes hydraulic effort down on the pelvic floor, up on the underside of the diaphragm, and it unloads the spine. Okay, but now let's measure the pressure and the exact amount of unloading effect that hydraulic effort creates. Now subtract the muscle activity and the compression it imposes in order to create the alleviation effect of the pressure itself. Now, let's look at those numbers. And then we did those calculations. And of course, the size of the person's belly, the size of their diaphragm, how far in front of the spine is the center of effort, and all of these things. As we calculated, the net is not an alleviation of spine load. It's actually costing compression through muscle activation to build the pressure, which then creates an alleviation. But the net is more compression. Well, oh, McGill, you have errors in your calculations. All right, let's put a pressure transducer in there. So you can insert them interrectally, and I can tell stories about inserting a wire up the anus and measuring intra-abdominal pressure. You can put one in the nose, down the esophagus, go below the diaphragm into the stomach, and that will give you a direct measure of intra-abdominal pressure as well. And it was concordant. So we were calculating correctly what the net pressure actually was. So we knew what. Anyway, a lot of science goes into this. Again, that people don't read the scientific papers. They tend to get swayed by short little statements, I guess, on social media, not realizing this.
So I guess in a hierarchy of importance, it is important, but it's nuanced and it depends on the individual. So you may use diaphragmatic breathing for someone, but you may not focus on it as much for someone else, is what I gather as
Well,
a general.
it's a detriment to performance. It doesn't transfer to really banging in a sport. You've got to breathe or hold your breath in a heavy deadlift, or do you know what I mean? It's
Sure, sure.
irrelevant.
I
But
think
if I
of the
have
shield and the
a patient,
inflation while I'm
if my
fighting, right? I obviously need a
sure,
certain amount
yeah.
of.
Oh yeah, take a kick to the midsection, doing a diaphragmatic breath. Things aren't going to work out well for you. So,
No, no, I need my shield on first, and then I can do that.
oh,
But that's actually one of the things I coach with people. I'll get them to take the diaphragmatic breath after I've built up the appropriate alignment, posture, tone, and then at that point, I try to get them not to release the tone while feeling the inflation from the inside. So getting them feeling the alternation of those two systems, right? The pressure from within and then the stiffness from without. Does that make
oh, okay.
sense?
So it's a definition. You're talking about breathing behind the shield, and okay, I get that. That's really wise. I was interpreting your diaphragmatic breathing to be a
More of a
relaxation.
passive sort of, yes, yes.
Right. Sorry.
No, no, that's okay. Like I said, there are many different definitions, so we should be clear about what we're asking.
It's only a discussion topic. There's no right or wrong answer for everybody. We have to converge on the answer. I hope that's the unifying theme of this whole thing. People want opinions, and they'll listen to a professor and they say that professor can't answer the question. And my response to that is, well, you can't ask the question. It has to
Mhm.
be for a specific individual. Give the variables that influence the conclusion, and then you work through all of those and you arrive at a solution that is best for that person.
Yeah, I think this is what happens a lot is where we're asking general questions or being asked general questions by the public, and then we're asking you, but you're trying to give a very specific and thought out answer. And I think that's where the disconnect happens a lot, where people
Well, if you don't know
misunderstand.
anything, it's easy to have a set opinion.
Sure.
But the more you know, the answer is a cerebral exercise, and then it becomes a physical skill exercise. Can you coach this? It's
Hmm.
hard to find people that can do both.
All these tangents that I'm trying not to go off on. And one of the things I want to come back to again is the disc real quick with Brian Carroll, because we spoke about the, let's say, degradation cascade of the disc and the different mechanisms. And I forgot to ask, I wanted to ask about what was it that made Brian's case so special? Because as you look at the MRIs before and after the rehab protocol, without surgery. He did very well. He made new world records. But when you look at the MRI, it seems like water has returned or disc height has returned, or there's signal there compared to the previous MRIs. So I wonder what am I really looking at in terms of recovery? As we know, certain things can be helped, some things can be managed, not all things can be reversed. But that to me, to my eyes, looks like a reversal to some extent.
I'm taking an educated guess in my explanation. I've tried to repeat it with different athletes. Sometimes it's successful and sometimes it isn't. And I'm trying to figure out what the nuance of it all is. So here's where I stand right now. First of all, can you adapt heavily damaged tissues? Bone, if we separate it out, and end plate, sometimes, for some reason, a callus forms over the break and it fills in. I hope we encouraged that with what we ended up calling bone callousing. So he would stimulate his spine with load and then take 5 days off before he did it again. So he would start with unilateral kettlebell carries, not heavy. Every fifth day is where we started on that. So you stimulate the bone, you encourage the building blocks of bone, the potassium and calcium ions to scaffold in. And we do know it takes several days for those scaffolds to form because if you train every day, the scaffold forms and then breaks off with the stress the following day. So I like to think that that was part of the mechanism, but it's peculiar to bony tissues. The actual disc is interesting in that he didn't have much height loss when you look at it. He didn't completely flatten the disc. So was there 70% of the original height remaining? Perhaps there was. But he didn't test the collagen through a range of motion. He just tested the collagen with isometric loading, hoping that the collagen that does adapt is the type X. So as I said, collagen type 1 and type 2 are the major collagen strands that form the annulus of the disc. The binding collagen that holds them all together, there's several subspecies and phenotypes, but let me just say, we'll call it type X, make it a bit more simple. He adapted collagen type X through the isometric loading to become stiffer and tougher. But if you took it through a range of motion, like in a Jefferson curl, as an example, you're now adapting mobility and compliance. But that's not what he needed. He needed more stiffness and the ability to contain hydraulic pressure to eventually lift 1,300 pounds, as you know. Those are the two components to start the discussion. I shall also say that Brian is an extraordinary human. He is so far beyond being what is average. If you've ever been with an athlete who picks over 1,000 pounds off the ground, you know you're with a very special athlete. What is strength? Strength begins in the brain as a thought, and that thought gets translated into nerve pulses. You need to have a very special brain, a very special emotional state, a very special hormonal state to densify that thought of strength and then have the capacity to carry it down the nerves and strategically distribute it through the body so that the torso and the core is stiffened and controlled, but the hips are still unleashed. Otherwise, she couldn't move to move the bar primarily. I mean, the hip power is the highest power in the body. So to have such a physically unusual specimen to start with may have something to do with it as well. There are a bunch of other variables that make Brian and his training and everything else about him highly, highly atypical, rare. Again,
So he's a good picture of what's possible, but not a common case scenario.
Well, if you could find another person who could squat 1,300 pounds,
Silly thing to say, I realize.
Yeah, I mean, if you're in a room with someone like that, take him. A great clinician has an almost sixth sense, an extra sensory perception. You can feel the room electrify as that density of strength starts to form. You can feel it in your own body if you're perceptive to it. That massive, massive strength of thought. That's very rare among humans.
Listen to you, I think of a tiger that vibrates or purrs and they heal their bones faster, right? This kind of thing.
Well, the Russians have been doing this for years with electrical current in stimulating bone. Yeah. So thank you for that. There's another possibility that maybe that worked with Brian to have such a incredible. And I must say, I couldn't believe it myself. We did an MRI a couple of years later, or don't quote me on the couple of years, but it was later. And it was like, what on earth? I hadn't seen that kind of healing. That was the first time I'd seen it. And then I said to Brian, they've mixed up your MRIs. That's not, come on. And his sister was actually an MRI technician down in Florida. And so she arranged for it all to be redone again. And the other thing is, Brian is, he's over 300 pounds. The man is dense. It's really hard to see. So we imaged him again. And okay, I believe it now. So, it is what it is. Can I explain it? Not really. But
and I appreciate that answer. That's a fair answer. There are things that happen that we cannot always put our finger on exactly and define. So
he's an incredible human. He's going to give me the gears when he hears this, but he is one of a kind. I've talked to his dad about this, which is kind of funny. I said, where did Brian get his strength and power from? And his dad just has no idea. But I don't think, forgive me, Dad, for saying this, but I don't think he understands the magnificence of his son. He doesn't understand that he's the one guy in human history that has done that and how special that is. I appreciate it every day. I interact with him a couple of times a week still.
That's
But
great.
yeah, he's an extraordinary uh, individual.
Last year, I took a ergonomics certification, and that was quite good actually. But what that did was I went back to what that caused was I went back to your book and I started looking at your commentaries on ergonomics in the past. And I found 3 points that I've 3 or 4 points that I've taken out of the books that I'd like to discuss with you that maybe you could help me expand upon a little bit. And this is meant as a constructive criticism of ergonomics for the sake of actually getting better results when we do work with companies. You've pointed out that traditional ergonomics often focuses too heavily on reducing load, rather, which can be an oversimplified view. You've said optimal tissue health requires the right amount of loading, which makes sense, not too much, not too little. And you've said that industrial ergonomics hasn't fully embraced the value of load variety, posture change, and movement patterning. I'd really love it if you expanded on that statement.
The mantra of ergonomics is modify the task to suit the person. And I believe, and I think I can prove, that why not modify the person? Why not do both?
Mm-hmm.
It's two different expertises, but put the two together. So when I was a professor at the university, I mean, I worked in ergonomics as a consultant years ago, but I'd be frustrated in that people would say, well, this isn't ergonomics if you start working with the person. And the unions, believe it or not, there would be
Mm-hmm.
some resistance sometimes to say that person is better suited than that person over there to do that particular job.
Mm-hmm.
Well, you can see how that would disrupt a union. So they focus on changing the job, and I have to consider both.
You'd made a statement that it was time to go beyond the chair and desk and start talking about muscular preparation, movement training, and teaching tissue tolerance in the workplace. And I guess this falls into what you just said.
Well, I'll give you an example. There was a company that made tires. They were a tire manufacturing plant, and they paid out $1.25 million the previous year in low back compensation. So the management came to me at the University of Waterloo and said, we paid out 1.25 million. And not only that, the employees that we had to train to do the jobs of the injured workers took time. We lost productivity. It was a really expensive thing. And they said, can we hire you as a consultant to come in? So I looked at the jobs, and then I realized that we needed some movement skill training for the workers so that same person could do the job with less stress on their body and save their knees and their backs. And I ended up calling it job coaching. So we would take one of our kinesiology students and put them in the plant for a work term. And then we trained the occupational health nurse in the same ideals of, yes, you have to pay attention to the person as much as you have to pay attention to changing the job. Let's call this job coaching. It cost the company $250,000 for the student, the retraining, training the public health nurse, and rolling the program out around the various job stations in the plant. Cost $250,000. The next year, they saved 5 times that in reduced back injury. So the investment of job coaching was paid back in savings times 5. So that's a pretty powerful argument for job coaching,
Mm-hmm.
trying to reduce stress in the worker through individual movement changes, as what did you call it? Muscular preparation and movement training, I guess.
Yes. Yes.
And having said that, if you get a person who sits all day at a control station in a plant and they have back pain, they don't need their job made easier. the ergonomist came in and gave them an ergonomic.
Yeah.
So they
Mhm.
sat in the ergonomic chair. Even more. Do you think the ergonomic chair worked? No. You had to put in a rest break. Well, what's the definition of a rest break? It's not rest. It is the mechanical opposite of the chronic work. So if the
Right.
work is to sit, stop sitting, get out of your chair and do strategic stresses to mitigate, which would be, stand up, reach for the sky, fill your
Mhm.
lungs with air. Let's do some breathing. And then if you measured the psoas would become stiffer and they'd be walking flexed, bent over. The gluteal muscles were not activating as they should for walking. So the specific mitigator of long-term walking was gluteal activation patterns, posterior chain training, opening up the facet joints, extending the spine, to directly mitigate. So there you go. We had to make their job more demanding to increase their health below the tipping point. The next person was lifting rubber tires. Now, their job was overly demanding, and they were getting a different type of back pain pathway. So their intervention was less. So we went through the plan job by job and job coached it,
Mhm.
optimizing the stress in the person's body from their own personal movement patterns, coupled with the design of the job. Why was it necessary for them to pick up the tire and the tire was presented to them in the sagittal plane? Why not turn the tire and now they can hold the tire two-thirds closer, two-thirds
Mhm.
less load on their back? That was an engineering change. There are administrative changes as well. How long is the work shift? When is there breaks? All these kinds of things.
Mhm.
Is it really wise to pay overtime? In some jobs, it isn't. They're already overloading their bodies, and then to pay them overtime to work even longer increases the injury risk. Instead of paying overtime, just have another set of workers. Again, as a whole thing, how do you train them and all the rest of it? But do you see what I mean? There's just an example of an administrative kind of approach to it. But a job coach is savvy to all of these possible interventions.
Great.
They'll,
So that's a
they'll
good
have them
answer.
in
What I'm
full effect.
hearing is it's not just fitting the task to the person, but the reverse also. It's both. Also, not just work hardening, but that's one piece of the puzzle along with everything else. I just remembered the presentation that was given to us by someone trying to sell or a company trying to sell an exoskeleton, and they had come to the meeting and they gave us a great presentation. And as part of the video, you could see a person with very poor lifting form lifting heavy things with the use of this exoskeleton. And of course, my trainer brain was thinking, are we sure this is a good idea? Because it seems to me like we're making this job so easy to execute badly that we're going to corrupt movement patterns for this person. And then what? So,
Well, I've
uh,
seen a couple of different exoskeleton designs. One of them requires the spine to fully flex because it's elastic bands on the back. So I get what you mean. Other ones use levers though, and they change the moment arms of things so they can lift with what would be considered conserving in terms of joint stress movement patterns. So maybe it was
sure.
just the design of the exoskeleton. But
Yeah, my
consider
point is,
let's go back to Brian Carroll. He lifts in a lifting suit as anyone would who would lift those kinds of weights, right? What is a lifting suit? Well, when you think about it, it is fascia, artificial fascia, creating a mechanical composite out of the body. It's just an extension of the fascia. Well, could you create a better fascial system through training?
he already
Uh,
has
the,
probably.
well, the answer is yes, by the way. But anyway, this is why these discussions are so much fun.
I think I'll bring it back to the BackFitPro network, the community, a little bit about people looking to help themselves. Professor McGill, can you please tell the listeners a little bit about the network itself, who the professionals are, and what they do to stay in touch with each other?
We have a company, backfitpro.com is the website. And if people would like to see a clinician, Paul is one of them that we've trained. Those clinicians have been through our courses, they've written our exams, and they are audited every 4 years for their competency. So that's one purpose of the website. We have our books there and some other things. My full literature, I've published well over 250 medical publications, all detailing different experiments. They're kind of boring to read, I suppose. That's why I wrote textbooks, to try and synthesize them all together. It guides people to those. What do we do for clinicians? We have professional development weekends as well. So next month we have an invite to our clinicians. They come here, and I will see a patient with them on one day for a couple of hours, and then we workshop it for the rest of the day as all the clinicians. What techniques did they see? What was the logic that we used? All this sort of stuff. And we do the same thing the next day as well. We have 3-day workshops here at BackFitPro for our clinicians, where we hone skills, clinical logic, but we also have a lot of fun as well. We have some great meals and a little bit of a party. We like to work hard and play hard at those things, I would say. But anyway, that's the purpose of BackFitPro, for people with pain and for clinicians.
I definitely encourage people to take a look at that list of professionals that you have in your group. I'm personally very grateful for the time that you spend with us online when we do have our intermittent family meetings, as we call them, with all of those skill sets, I would say under one roof, but let's say in one digital space together. We always get tips and experiences from one another. So this is a very valuable thing, this interdisciplinary approach whereby you've got people from all disciplines converging on the topic of back pain within the realm of your methodology is a really great group. So people can find that on the website, all of their contacts. And I highly encourage for anyone who's struggling with back pain, regardless whether they're trying to help themselves through avenues such as back mechanic, online or otherwise, to at least spend some time with a highly skilled clinician, get a thorough assessment and some feedback on execution and what are the low-hanging fruits, as well as what to do and what not to do in order to facilitate faster and more effective healing. So with that being said, I thank you so much for your time today. It's very, very appreciated. I know it is scarce. I look forward to having more conversations in the future if possible.
Okay, well, Paul and Marcin, thanks so much for your support and for looking after the people that we send you and creating a good outcome. So thank you for all that you do as well.
Thank you.
Very good.